So basically, I'm going to talk about bladder and bowel health, and then for those of you who know Lucine Embartsumian, she's one of the pediatric gastroenterologists at Children's. She is absolutely wonderful, and Lucine and I often give this talk together, so I have stolen some slides from Lucine, with permission, of course, but I think it's really important because bladder and bowel health really go together. Sadly, I have no disclosures. I am not going. Oh, I have to next. Okay, next slide. Thank you. I still have no financial relationships. All right. Pediatric bladder and bowel health. So I'm sure that all of you have had the experience, particularly around this time of year, when people come in and they say, this is a problem. So-and-so starting school next week. We need this fixed. And the response to this, all joking aside, this was a simple problem. People would have fixed this already. It's not just one thing. The other thing is, this is the Eber's Papyrus. This is really old. I forget exactly how old. I used to know. I think it's like 45 AD, but this has been going on for millennia. So if we haven't solved it in the last 2,000 years, probably not going to get to it before Tuesday. So just to put this in context, longstanding problem. This has been going on for a while. I'm going to give you some tips and tricks. I'd notice I did not say solutions in my talk. Next slide. Okay, so my objectives today, we're going to talk about the anatomy and physiology of the urinary tract, all that physics you thought you were never going to use again when you took the MCAT. We're going to talk about that. We're going to talk about organic and functional disorders, and we're going to talk about how to start the evaluation, particularly with regard to constipation and pediatric bladder and bowel health. And the reason I included some of the talks, the slides from Lucine, is because not only that is bowel health really a driver of bladder issues, but she actually gives some recommendations for dosing and that in the slide, so hopefully that will be useful for you guys to take home. Next slide. Okay, so everybody tells you syphilis is the great imitator. They tell you lupus is the great imitator. I would say urinary tract dysfunction is the great imitator. So I get a UTI every month, running to the bathroom, something hurts, penis, vagina, testicles, and it hurts when I pee, and then that's it. So what is really common about all these are all really vague, right? So I won't belabor this point, but this is really where all of those data about exactly what's happening, where exactly does it hurt on your penis, what makes it better, what makes it worse, that really helps with this. And most of the time we'll find out that these really vague symptoms are in fact related to elimination issues. Next slide. Okay, so some myths about lower urinary tract issues that I often have to dispel, and I'm sure you do also. There is no problem if you're dry. In fact, the worst problems are if you have lower urinary tract issues and you are dry. People don't think it's a problem. It's very hard to get buy-in to fix it because they aren't, the problem actually is the urine leakage. For many people, the underlying problem for us is the renal failure that comes from them being hypercontinent. The child is incontinent on purpose. I'm not going to say this never happens, having had a dog who the other day literally looked me in the eye and then peed on the new comforter I put on the bed. However, I'm going to say kids are probably smarter than my dogs, and they don't generally do this on purpose. The bladder is too small for the child. Unless there's actually an anatomic problem like an bilateral ectopic ureters or a neurologic issue, your bladder is a muscle. So that is like saying, my bicep is too short for my arm. No, it's not. Just go stretch it. Doesn't make sense. Offering access to a bathroom is sufficient. This is my favorite. Well, we have a bathroom. Where do you live that you do not have modern plumbing? Of course you have a bathroom in your house. That's not sufficient. And then urethral dilatation will fix the problem. This, thank goodness, I think this has really gone away. But this used to be one of the most common solutions. And yes, I do understand why it worked. I'm not even going to talk about why it worked. It's not a long-term solution, but sometimes people will come in and talk about how that was done years ago. Next slide. Okay, so normal voiding. On the left, you have the picture that you probably all learned. On the right, you have the picture I draw for my patients. You can see that there's some differences here. Work with me here. So what happens? This is exactly what I tell people. Obviously your kidney's not in the middle and there's two of them, but blood goes through, urine comes out, goes down this tube, goes to the bladder. At some point you relax this is your sphincter muscles, your pelvic floor, and you pee. So you'll notice I drew this so everything goes straight down. What happens when you are at a point where you do not want to pee, or, sitting in traffic right now, you are sitting in this talk, you really have to pee, but you don't want to miss a minute of what I'm saying. What are you going to do? You are going to contract these muscles. This makes the twitching of your bladder stop. Over time, you can really stretch to hold things, but what happens more often is, later you're like, I probably should pee because I haven't gone. I'm not wet. I don't feel like I have to go anymore, but the urine must be somewhere. It must still be in my bladder. And you go and you're like, wow, there's a lot of pee in there. So you can actually train yourself to hold incrementally more. I know this from 8 years of residency and fellowship. I personally have done Uroflows. I do not feel like I need to pee till I have 987 cc's in my bladder. So I do empty completely, however. But that said, all of us, if you actually were to come to my clinic and do this, we all probably have above average capacity bladders. So again, just because you're not leaking doesn't mean you don't have a problem. So what happens, this message goes to your brain, and then you kind of go, can I go, can I not go? So if there's a disruption in the making of the pee, which generally there's not, that's nephrology, the sensation of needing to go, the ability to push everything together to keep the plug in, or the message to your brain, you're going to have a problem. Next slide. Okay, so quick review of meaningful stimuli. So this is a train crossing. So you'll notice here that we have some gates, we have some flashing lights, and then we have a lot of bells. The bells are here, and there's some down here too. So things that are meaningful to your brain are things that are different from the background, they are intermittent, and they're episodic. So they don't happen all the time. They are very different from the background, and they are, when they do happen, there's not just a it's okay. So if you think about things that are really, really important, blue lights on a runway, they're very different from the background. They're only in one place, and there's dots. There's not straight lines. Same thing for like when you're on an airplane and they change colors. Part of the reason there are little dots versus just one strip of color, it's not just to make it easier to replace the bulbs. It's actually because you're able to see and discriminate those dots differently and more accurately when you're under stress. Same thing with sounds. So when trucks back up, why did they beep? Because that makes it different. Why did you get a beeper? Those of you who are old enough to get a beeper versus something that just makes a horrible sound, because it will wake you up. So all of these things, this intermittent nature of the stimuli is really important. And where we run into trouble is, can you go back one slide for just a second? When this intermittent feeling of needing to go and stopping it becomes constant, and you feel like you have to go all the time. So because you feel like you have to go all the time, the feeling of needing to go all the time becomes your background. So your brain's like, okay, just like if your pager went off like all day, like it's constantly going off, you're going to miss a couple of pages because you just can't keep up. You can go forward 2 slides. Okay, so we're going to talk about some of the different presentations, and hopefully I'm going to try out my some of my props. Okay, so urinary urgency is the clinical presentation is I need to pee right now, I can't hold it for one more second. So what do we see? We see the kids doing the potty dance, grabbing their crotch, sitting on their heel, and then and that's called Vincent's curtsy, and we'll also see recurrent UTIs, some real, some not. The literature says 5 to 7-year-old girls, in my experience, I think it's younger, I think it's older, I think a lot of them are male. I could kind of go off on a bit of a tangent on gender disparities in continence care. I won't, but that's the board answer is 5 to 7-year-olds. I don't know that that's true. So where's the problem here? The problem here is one of 2 things. Your bladder is too twitchy, or you can't hold in the, you don't have a strong enough pelvic floor, or both. Just having not enough of a strong pelvic floor is not going to cause this. So, Owen, can you help me? Okay. Owen is my assistant, so a little clap for Owen. All right. So I'm going to have you go over there and see that thing with the red bottom? Nope, the other one, the thing that's sticking up. Oh, yeah. Bring it on over to me for a sec. Okay. So this is my bladder. okay? So we have a bladder, and we have a very long urethra on my bladder, but stick with me. Okay, so Owen, I'm gonna have you hold this for me by the top, okay? And then hold the top for me. Hold up here, okay? So Owen's gonna take his hand out for a second. Scoot over there a little, Owen. And take your right hand away. So he's leaking a little, squeeze the top for me, just real fast. Perfect, okay, flip it over. So you can see, thank you, Owen, you're all set. You can go sit down for a sec. Thank you. All right, so that's a bladder spasm, okay? So what's gonna happen? You're gonna leak. So that's just water, I promise, it's fine. So what happened there, the outlet was not strong enough, and it was actually also not flexible enough to adapt. So fixed resistance is also a problem. So that's urinary urgency. Thank you, Owen. Next slide. All right, stress incontinence. So stress incontinence is when the pelvic floor is not strong enough. So the problem is here, okay? So when do we have this? We see this when there's sudden impact and a sudden increase in abdominal pressure, so sudden increase in Valsalva. We see this when also when people are not able to keep their pelvic floor as tight as the rest of their body, and we'll talk about that in a second. So high impact sports are where you see this. So people who go to Orange Theory, I don't know if you ever read the Orange Theory Reddit, but everybody wants to know what color pants they can wear on a certain day. And if it's the day with the burpees, everyone's like dark pants, maybe a pattern. So gymnastics, 67% are leaking. Nobody in golf is leaking. Apparently golf is not a high impact sport. Lifetime sport though. It's associated with decreased foot flexibility, not caused by it, but that's because if you have decreased foot flexibility, you tend to have tight muscles in your back, and we'll talk about why that's a problem, as the posterior chain is tight. And it's also associated with increased force transmission, because when you land and you push down, the weakest part's gonna be your pelvic floor. So if you go to the next slide, this is another picture I draw people. So you're a box. It turns out everybody's a box. Your abdomen, your diaphragm's on the top, all your lumbar muscles are on the back, your obliques are on the side, your core, your abs are on the front, and then your pelvic floor. So if you have a great diaphragm, and you do, because you breathe well, if you have a good back, which most people do because we're standing upright, if you have a decent oblique and core, then the weakest part is your pelvic floor. Now, what happens if your core and your obliques are weak? If you're carrying a box, like you're moving something, and the box starts to bulge on one side and rip, what do? You tilt the box, right? And so what happens when you tilt the box, now everything's not in the right orientation, right? So now everything, the dynamics, the actual forces have to change. So I'm sure we've all, maybe it's just me, have had this experience where something's tight up in your back, up here, and it turns out that like your foot hurts, right? And so everything is very interconnected. So if you have problems here, or even here, we see this sometimes in kids with CDH, you will actually have a problem with your pelvic floor. So it all fits together. I also gave my patient really flat feet, but that's just because, so don't pay attention to that. But the important part of this is the basis for some of the physical therapy that we do. This is why biofeedback alone is often not effective, because you need to deal with the muscles as well. So part of it is awareness, and part of it is being aware of the sensations that your body are giving you. Part of this is also just making sure that the muscles are all working in concert. Next slide. All right, and then the bladder-brain connection. So this is really part of why bedwetting is such a problem, because most people do not come to you with isolated daytime incontinence. They will often come with isolated nighttime incontinence, but isolated daytime incontinence is really rare. Why is nighttime incontinence a problem? Well, first of all, you're still making pee, maybe not as much. Everybody's really, floppy at night, so this is not tight to begin with. But when you feel like you need to go, you can't tighten this up. And plus, you're sleeping. Like little zzz up here. So even if you feel these bladder spasms, you can't contract volitionally, and you don't have enough outlet pressure to keep everything in. So it's really, to be honest with you, it's pretty surprising that more people don't wet the bed. All right, next slide. Okay, so bedwetting alarms. So this is why bedwetting alarms don't work. They do work, but they don't work for most people because most people do not set themselves up for success. So the thing with bedwetting alarms, let me just tell you exactly how these work. So first of all, there's urine. There's moisture, the alarm goes off. It beeps intermittently. Guys, have you ever heard it go off? It's really loud. Okay, it will wake everyone but the child up, okay? So what happens? You, the parent, with the multiple circles under your eyes here, you have to wake up. You have to go wake up the child. And when I say wake up the child, I mean wake them up. Like they are up for the day. Like you're gonna go catch a flight to Scotland awake. Not let me just walk you to the bathroom. Like everybody's awake, like fully conscious. We could do your math homework right now awake. And what this is ultimately, if you do this fast enough, which is one of the keys, moisture wakes up the child. And then the feeling of the bladder spasm, which precedes the moisture, will wake up the child. So this actually works perfectly, except, let's be honest, everyone's tired. You think, like, I'll just give it a couple of minutes. Or maybe we'll skip this time. And then what happens, you train them to sleep through the alarm. So the other thing is that this doesn't go off once a night. Okay, people don't necessarily wet the bed once a night. They can wet the bed 8, 10, 12 times a night. So I'll talk to you a little bit about how to make your elimination habits better so that maybe instead of wetting the bed 12 times a night, we're down to 4. But if you don't set yourself up for success, let's be honest, if you were getting up 12 times a night, that would be terrible. You'd give it up. I would give it up. So setting yourself up for success so that you can actually do this every time. And if you can do this every time, it works great. But theory and practice are different. All right, next slide. Okay, and then I want to just talk for a second about myogenic detrusor failure. This might seem a little bit like a non sequitur, but I just want to, there's really nowhere else in this talk to put this, so I want to throw it in here. These are the kids who are hypercontinent. These are the kids who had an outlet obstruction and the muscles of their bladder they don't interdigitate anymore. So what happens is you basically get dilated cardiomyopathy. You get heart failure of your bladder. It's the exact same concept. It's a hollow viscus that can't push. And what happens is they can't empty. And then you end up with a lot of fluid in there, and then the pressure in the meantime often goes back up towards the kidneys. In this particular case, you don't see reflux up towards the kidneys here, but sometimes you will, but the pressure is still there, and that pressure pushing on the kidneys is what damages kidneys. And this is actually a pre-transplant evaluation in one of my patients. All right, next slide. Okay, so let's talk about what do we do now? So is this organic or is it functional? So organic is there's an actual problem. Functional is there's a really big problem. So when what we're looking for is red flags. We're looking for neurologic deficits and asymmetry. So somebody who comes in to see me and they're limping. Somebody who comes in to see me and they're walking like this. Somebody who comes in to see me and they're tripping on their shoes and their shoelaces aren't untied. If there are other comorbid conditions. So, things that I'm always thinking about are, does this child have a tethered cord? Does this child have something neurologic in their spine? So sometimes people have a syrinx and you don't see it till they're older. Things like that. We also want to check urinalysis. Usually this has already been done when the patients come to see me. I think most pediatricians, most primary care providers already do this, but you're looking for glucosuria. You're looking for diabetes, you're looking for concentrating ability. So if most of the time you'll see that they have urine with the specific gravities up in the high 1.02s, but every so often you'll see someone who has terrible bedwetting and you look in their specific gravities like 1.003 and you're like, I have an idea. Actually, I don't think it can actually be below 1.008, but you see my point. They're very dilute urine. Hematuria, and then is there an infection? Now, infections, we will talk about this in a second as well, but make sure it's a real infection. So the criteria for infection are very specific. I will say that it's over 5 white cells per high power field with symptoms. I also will tell you that 6 to 10 white cells is definitely something where I'm like, I'm not sure if that's actually an infection. So most people have a lot of white cells. If you only have a couple, I would treat for infection, but I would also keep an eye out for something else. And then voiding diaries. I'm putting this on here, like at the bottom, nearly in the cutoff of the screen. I know some people love them. I hate them. I assume that everyone does what I would do, and they fill it out in the parking lot of the office ahead of time, trying to find 3 different colors of pen so it looks like they did it ahead of time. And like nobody does this. Like they just don't. And if they do it, it's so detailed that it's almost useless. So I personally do not find them helpful. I have colleagues who swear by them. So I put them down the bottom because I don't really think they're useful. Next slide. Okay, what is useful is getting an idea of how people pee. So here's your uroflows. These are actual uroflows of actual patients of mine. So what you should see is this, but maybe a bit more stretched out. So tower shaped is I'm pushing to pee. I kind of sat down and I peed real fast. You probably can't see the numbers here, but it's how quickly you're peeing. So this is 5, 10, 15, 20, 25 cc's per second. Women generally pee about 50 cc's a second, men 25 cc's a second. Same for kids. We have the plateau. This is an obstructive pattern. So it's like you're trying to pee and you're only peeing about 5 cc's a second. This can be normal, this kind of pattern, after something like a hypospadias repair, because again, you have fixed resistance when I put the urethra back together. But most of the time, if you have normal anatomy, this would not be normal. Abdominal straining. This is, I'm pushing to pee. I'm like really bearing down to pee. And then this is staccato peeing, where you have some pelvic floor tightness. So these are kind of similar, but the abdominal straining tends to be a little more consistent, whereas the staccato tends to be, you don't tense your pelvic floor with the same consistency as your abdomen. So this is, when we see somebody and they're kind of peeing like, we know that they probably are either pushing too hard to pee or they're not relaxing the outlet. Okay, next slide. All right, so let's talk about initial management. So drink a lot, pee a lot, poop. You guys have heard of this probably from me 1,000 times. So why do we want to do this? First of all, you want to drink enough water to keep the urine light yellow in color. People want to know exactly how much they need to drink. Your kidneys get rid of your water-soluble waste products. We live somewhere it's very hot. Kids also grow a lot. They have lots of waste products. So they just need a lot of water. I can't give you an exact number. What I usually tell people is they need to go to like Lowe's or Home Depot, pick the light yellow paint chip, and that's what they want. So like even the color of this room, too dark, okay? Really light yellow. And so remember, it's going into your toilet. There's water there. We want it to, be even lighter. Pee a lot. So you want to pee first thing in the morning, last thing at night. You want to pee every couple of hours during the day. Why every 2 hours? Because well, first of all, you're drinking a lot. Like there's the one thing. The other thing is that there are data that show that if you have bacteria in your bladder, which many of us do, that if you are able to void every couple of hours, that interval is sufficient to keep the bacteria counts from getting high enough to qualify as a UTI. So the key with this is that this is parental nagging. So I tell parents, this is your carte blanche to nag your kid. Okay, so first thing in the morning, your feet hit the floor, off to the bathroom. Every 2 hours, and everybody has to go to the bathroom, because often the parents don't have great voiding habits, because again, like I said, I don't have great voiding habits, but kids model what they see. They don't want to miss any of the excitement, but if everyone's going to the bathroom at 10 a.m., they're going to be delighted to go to the bathroom, but they don't like to feel like they're doing something different or punitive. And then poop, the soft BM every day. The Bristol Stool Scale, one of my favorite things. I like a 6. Lucine's a 5 to 6 kind of girl, but I think that we'll demonstrate later. Part of our other thing here is talking about smushy poop. But if you have soft poop, it will really help. Why is this? Because there's the steric hindrance from the poop if it's hard, but also the bacteria are different in hard versus soft poop. And so you have less bacteria and you have different bacteria if the poop is soft. Next slide. Oh, I'm sorry, go back one slide. I put these on here just about schools, because one of the things that I often hear is that people will say, well, they go to school, I can't control what happens to them during the day. But we are very lucky that the teachers in general with whom I have spoken are super invested in letting kids go to the bathroom and being very involved in eliminating some of these problems, no pun intended. School nurses and teachers really don't want to be part of the problem, and they don't want to have kids be embarrassed. They don't want to have, it's more disruptive to have somebody who's, has wet pants than it is to let someone go to the bathroom. So it turns out that they don't have a lot of knowledge about this. This is really an area for improvement in terms of going to talk to them. But I talked to the Yakima school nurses a couple years ago, and they were so excited to talk about pee and poop. It was great. But it turns out that the schools just don't know, and when you ask them to just let kids go to the bathroom or take the whole class to the bathroom every couple of hours, they're like, oh, sure, I can do that. I had no idea that was a problem. So don't discount that, because that's, I think this is a perceived rather than a real barrier in many cases. Sorry, next slide. Okay, so behavioral modification. So if you do the drink a lot, pee a lot, poop, the data show 30 to 50% will get better on their own. I think it's higher. I think a lot of people do not pee first thing in the morning. But a third will recur within a year. Why is this? It takes a long time to make a habit. Somewhere between 42 and 60 days, if you believe all the psych literature. I think it really takes a long time to make a lifestyle change. It goes up to almost 90% if we put in pelvic floor exercise and voiding diaries. Again, I don't really like these, but pelvic floor exercises with supervision, with someone showing you how to do this. We do not want kids doing Kegels. So this is where we put in physical therapy. So the important point with this is medical therapy is an adjunct to, not a replacement for, behavioral modification. Medical therapy is not first line. I cannot tell you how many times I see people, even people that are trained in urology, giving people medications first. It does not work. It will not work durably. Rare exceptions. For example, I got a call from a pediatrician a couple weeks ago for a little girl who didn't have a UTI, had incredible urgency and frequency. I mean, she was just going every 5 minutes. They were going to get a renal bladder ultrasound, but it takes 2 weeks to get an ultrasound now. Doesn't seem like anything else is going on. Can I put her on Ditropan? She's miserable. Sure, that is a bridge in that case. That is not a long-term plan. So I think that when we look at something, medical therapy, yes, you can give it in the early stages, but recognize that that's going to be treating an acute issue, not the chronic issue. And again, a couple of thousand years of a problem. This is a chronic issue. Next slide. Okay, pelvic floor biofeedback training. This requires very motivated kids and parents. So I don't know how many of you, probably most of you, I think I've sent your kids to some kind of pelvic floor biofeedback. So this pelvic floor biofeedback, what they'll do is they teach you to have control of your muscles and kind of individually contract some muscles and relax others and have some control over this. And they have a little video system where there's a spaceship, and the spaceship lands on the moon if you contract your muscles correctly, and then it takes off again if you relax them. It's really great. But it works really, really well. But you have to do this when your elimination habits are optimized. Because if you're busy trying to hold your pee in, you can't relax your muscles because you're afraid you're going to pee on yourself. So if you really do the drink a lot, pee a lot, poop, and you're that 10 to 12% that really need to have physical therapy, then you will do better with that. So in that study, like I said, 89% will have symptomatic improvement and 61% will have symptom resolution. The animation is really key because it's really hard to tell if somebody is contracting their muscles correctly, but electrodes don't lie. So you can do something where there's a flower that opens. My favorite is the space shuttle landing. There's a horse or a dolphin that goes through hoops, a horse that jumps over a fence. I mean, the options are endless. But it's really important because you want to make sure they're doing the right thing, because if they're not doing the right thing and they're doing the wrong thing, you can make it worse. Okay. And then, like I said, the animation, they did a study and then showed that objectively kids were able to empty their bladder better, have less outlet obstruction in their pelvic floor if they had animation. Okay, next slide. All right, so we're going to talk about the poop. So this is Lucine's wedding cake because her wife is a urology nurse and Lucine's gastroenterologist. That's how they met. So this is, I love that she put poop in here. I think that's hilarious. So anyway, there is only one ureter, but I think she's actually holding the hand of the ureter here. But anyway, I love this. I think it's hysterical. So anyway, what about the poop? Next slide. Okay, so these are some studies from Lucine, and then Owen's going to help me do some demos here. So we're going to talk about anorectal manometry and urodynamic studies, and I'm just going to show you the highlights. But basically, if you have problems with poop, you're going to have problems with pee. If you have problems with pee, you're going to have problems with poop. Why do people not complain about this? Because everyone has constipation, and it's actually a lot harder to leak stool. And again, the leakage is often the bigger problem, at least for families that bring us in. So what does this mean? Next slide. Okay, don't be overwhelmed. When I saw this, I was like, oh my goodness, why did I put the slide in here? But it's not that bad. You're looking at this blue one right here. This is the detrusor pressure, the pressure in the bladder. And then these two down here, the red and the gray, this is the proximal and distal intraanal pressures. So what do you see here? You're gonna see that the bladder should stay pretty calm down here until you void. But when you void, you're gonna see that normally you would see that the anal pressure would drop. Okay, so these should mirror one another. This also happens, so the reason that this is important is this is normally what happens. You can imagine that if you had increases in this pressure here, which would be back here with filling, you would see increased pressure in the detrusor as well, because you're peeing and you're emptying things out. So what that means is there's only so much space in your pelvis. Next slide. Okay, so people don't effectively empty their bladder when your rectum is distended, but they do leak more, and then they have increased voiding issues. All right, so this is where Owen and I are gonna try out my new thing. We're gonna see if it works. All right. Okay, so you put this down. So we have my makeshift bladder, one Ziploc bag, okay? We're gonna put this in, and this is my pelvis. Pelvis is a bowl. So Owen is gonna take our poop, a little hard ball, this is first for one poop. He's gonna put this in here. Was it on? Nope. Okay.
Testing. It's on.
It's on. Okay. So Owen's gonna put the poop in the pelvis for me. Okay. You gotta cram it all in there, Owen. Gotta really push it in there, because it's all gonna be below here. How's it going? You leaking yet? Okay, keep going. It might not pop. I don't know. You want to pull the bag out and see if we're leaking? Yeah. Okay. Because you saw it was dry when we started. So are we leaking? You're not leaking? Oh, you're leaking. You're leaking. You're leaking out the back there. Yep. He's leaking. Down here. Yeah. All right. That's probably good. There's not leaking everywhere. Okay. But you are going to leak now. Okay. But it's probably better than it's not leaking everywhere. You can find it over there, Owen. We'll be back. Thanks. Here, you put our food. Thanks. Okay. But he is leaking a little bit, just so we're clear, but I guess you all can't see that. But it's probably better that it's not exploding. In any event, but you will leak, and that is literally what you see is that little drip, right? And that's my underwear is always a little bit wet. It's very rarely the big gush. It's always I was doing laundry and the underwear is always damp. It really stinks. So then, all right, Owen, you're up again. So I'm going to try this out too. We're going to see if this works. These are underwear.
And your mic is off again.
Am I on now? There we go. I am undeterred. Okay, so we have some paper towels, which are underwear, and we have some chili flakes, which are bacteria. And we have our bladder. Okay. So hang on a second. We have our twitchy bladder.
This one works.
Okay. Oh, wait. Okay. Okay, so what you can do is you'll actually get a little bit of the bacteria stuck in here, which we did, and then we peed it out again. But you will be able to pull, when you have that dropper mechanism, you can pull bacteria in here. And then when you can't pee because you have bacteria, or you poop behind you, everything is angled and you can't empty it out as well. So thank you again, Owen. Appreciate it. I'll clean this up. It actually is not that messy, just for the record. We'll see how it goes next time. All right. So that's why that's important, though, because poop is made of bacteria. When you put moisture on things, and bacteria, they love moisture. It's like those Mucinex ads. And then you do this twitching, you're going to pull it back in to your bladder. And that's why you get these UTIs. So part of it is you get UTIs because you have bladder spasms. Part of this is people are diagnosed with UTIs because they have bladder spasms. So that's why early on I was like the recurrent UTI. But when people say that they have UTIs every month, it's usually something like that, where the dropper kind of pulling things in there, and then it gets better. Oh, next slide. Okay, so bladder voiding dynamics. Admittedly, the slide's a little overwhelming, but what we're gonna look at here is these solid lines are normal bladder pressure and abdominal pressure. So this is your abdominal pressure, the green. This is the red, the bladder pressure. So when you're voiding, you should start to see a drop off. And then when you distend the rectum, so that what Lucine did was fill up people's recta, I don't know. Anyway, she put a balloon in their bottom and inflated it. So there's increased rectal pressure. And then when they tried to void, you can see that this didn't drop, okay? And it was very high voiding pressure as well, because you have to overcome not only your pelvic floor resistance, but this resistance. And when you have lots of stool in your rectum, what do? You tighten your pelvic floor. As you guys will remember, there's a lot of muscles that are all attached to one another down there. And so it's very hard to tighten just one part of your pelvic floor. And so what happens is you end up with poop, making your pelvic floor tight, making it hard to void, making the pelvic floor even tighter, okay? So lather, rinse, repeat. The reason this is also important is because there are newer data showing that people who toilet train early are at risk for having voiding dysfunction. Why is that? Because there's two ways to be continent. One way to be continent is, oh, I feel this sensation. I need to go to the bathroom. Let me go. The other way is, I tightened everything up and I'm dry, right? Either way, the end result is you're dry. But if you're dry because of this, because you're holding everything in, that's sort of like saying, I've lost weight and I have complete control over my eating habits because I just don't buy the Doritos. That's different than, not being able to eat the ones in your cabinet. No judgment. I'm the person who doesn't buy the Doritos. But it's different in terms of how you interact with all of the thoughts and mechanisms with it. Next slide. So what's really key with everything, especially with the pooping, because oftentimes there's less of a buy-in with the poop. You want to get a really comprehensive history, do a good physical exam, and Lucine has a slide that goes with my other list of things you should look for. Think about symptoms, and then really want to think about, are there anything else that could be just causing this problem? And if there's not, go back here, and then treat. If the treatment doesn't work, your differential diagnosis is not right if the patient has given you accurate information, and then reassess for organic disease. So every so often, every couple of years, you'll see somebody where you're like, they're just not getting better, and I really think they're doing what I asked them to do. And they will have organic disease. They'll have a tethered cord. They'll have a chromosome issue. They'll have some kind of myopathy. Not very common, but most people, it's really tough to do the treatment. But if they're really doing it and they're not getting better, then you need to think about, is there something else going on? Next slide. Okay, so this is the one. Alarm signs and symptoms. This is also for urologic issues, but early constipation, passage of meconium, family history of Hirschsprungs, and then failure to thrive, fever, bilious vomiting, severe abdominal distension, abnormal position of anus, and then you kind of look for neurologic abnormalities. These are the ones that really apply more to urologic issues. So kids with a gluteal cleft deviation, a sacral dimple that's not in the gluteal fold, or you can't see the bottom of it, tufts of hair or color differences, changes in their lower extremity strength, tone, or reflex. So we'll often see, I don't do gym class because I have bedwetting, and then you find out they have a lot of lower extremity fatigue, and then you're thinking tethered cord or something, and then extreme fear during GU exams or scars. So this slide is really, really helpful. This is one that I give my medical students when I'm just things that they need to be thinking about in terms of neurologic and other issues that cause the uncommon causes of common problems. Next slide. Okay, so what are our goals of treatment for the GI tract? Facilitate colonic emptying, including anal emptying. Ensure continence, because we can make everybody empty, we just can't necessarily make it predictably empty, right? Anybody done if you do a colonoscopy prep, right? Same idea. And preserve colonic neuromuscular integrity. We want the system to work. And so we really want to balance their quality of life with all of these things. And so this really goes back to that whole story at the beginning where I said people want an easy fix. I can make everyone continent. I can take your kidneys out. You don't want that. So we have to balance this. And so if this was easy, we would have done it already. So I can get to your goal, but what's your real goal? People's real goal is a better quality of life for them and their children. It's not actually the continence. And so continence is a part of it, but there's always a trade-off there. Next slide. Okay, so non-pharmacologic treatment for better pooping. Soluble and insoluble dietary fiber, good fluid intake, physical activity, because you have to strengthen your muscles there, pro and prebiotics, behavioral therapy, and then biofeedback. And the biofeedback really goes with the physical therapy. There are studies that show that biofeedback alone really doesn't work for most kids. It really works best in conjunction with physical therapy. So I like biofeedback, but I love physical therapy. It's really hard to find a physical therapist that will work with kids for this. Luckily, the Tri-Cities has one, but it's really, really hard. So biofeedback is better than nothing, but it is not generally sufficient. Next slide. And then, actually, I guess this is what I was going to say. Physical therapy is great. Works for everything. Next. All right, pharmacologic treatments. This is what leucine tells people to do. Start with Miralax. You can give them lactulose. You can give them milk of magnesia. These are osmotic laxatives. As you guys know, these will make you poop. They don't always make you poop in a really predictable fashion. Don't start these on Monday morning. Really just, titrate these up. Stimulants will also work. These are really the areas where here, and then if you're getting into here, you probably need a GI person. But mineral oil and colace, and then enemas. A lot of people are very averse to giving their children enemas. I know there's a urologist who's a big fan of enemas. I don't think that you necessarily have to start there, but I also when I talk to families, I talk to them about using enemas that sometimes you just need a little help from the bottom to get things going. But that said, I don't know that you necessarily need to jump to enemas, but I try to really reinforce that they are a normal part of emptying the rectum, that rectal stimulation is really important. Sometimes we'll just start with suppositories. There are no randomized trials of optimal dosing in kids, but usually I start with 17 grams and just titrate up and down, 8.5 if it's a really little kid. And then for the Senna, I just give them one tablet and go up. I might go to 2. But typically, there's no randomized controlled trial in part because everybody's a little bit different in terms of what they need. If you're just changing the poop for the most part, like mineral oil and Miralax in general, it's pretty hard to overdo it. Like you'll have too much poop before you'll have a problem. But the stimulants, they act on their muscles, so you can have a bigger problem with that. So I titrate those more carefully. Next slide. Okay, so when do you do this? Do this for at least a couple of months. Leucine, before she likes to see people back, 3 to 6 months. When do you stop it? Because people always ask, when do you stop it? Once the symptoms have been gone for at least a month, they've completed toilet training. I also don't do anything until they've been stable for a whole year. Again, because we know that 30 to 60% of people, when they have behavioral changes, it won't be durable. And there's nothing worse than I was doing great and then I wasn't. So I really try to have them in a really stable setting before we take anything away. Next slide.